moving towards figuring out how to address that. And some of it comes back to views of us, them, right? Everybody, here's the way we do it. Here's how things work. We have some new kids on the block here. The new kids on the block are the QHINs, and partly by being required and partly because of the value that they're going to bring. And it sort of reminds me a little bit of remember financial networks and ATMs? Well, that was just one use case. There was Cirrus and Nice, and I think Mac it was, right? And they fought, and it was hard, and you had a bank card, and it would work, but not at that bank. Eventually, that went away. Maybe in 15 or 20 years, we may get there. Our moderator for the next panel is Kevin McAvee. Amazing individual. He'll do his own bio as part of his presentation, setting the stage. So we'd like Kevin to come on up. But I will share that even though he'll introduce himself, I wanted to notice that his impressive set of colleges include 2 in upstate New York, Colgate and Cornell, very great institutions. So come on up, Kevin.
Better?
Better.
Okay. I hate this because I can't see you guys. I'm not tall enough. It's really nice to see you all. Good morning. It's a pleasure to be here on Halloween. I was gonna come dressed as a Yankees fan, but I missed it by missed the last costume by 1. I missed it just by 1. I love New York, and it's wonderful to be at this event. And I would actually just love to get a sense from all of you where you're coming from in New York. So if you're from if you're based in or work on Long Island, would you raise your hand? Okay. How about in the boroughs in New York City? Okay. How about upstate, which I think some folks down here consider anything above like north, like with White Plains. Okay. So we have a good spectrum here. How many of you working on the ground at a provider? Okay. Plans? Vendors to the community. Really helpful. And it's also just great to know where we're all coming from, particularly if we're coming from out of state. And I think though that just exemplifies the types of gaps where we are hoping to fill in our environment on a daily basis. My name is Kevin McAvee. I'm a managing director at Manat Health. Health data is at least my professional life, from health information exchanges to APCDs, health data utilities to health data organizations, California to New York, Montana to North Carolina. I think about clinical data, claims data, vital statistics every single day. I'm proud to and privileged to have had the opportunity to support the establishment of the data exchange framework in California. Now working with David and nice to think about what the future holds for New York, as well as having the opportunity to set up some of our state health data organizations. I love New York, as Al mentioned. I grew up on Long Island, lived in central New York for 8 years. I live in Westchester now and work in New York City. Through all of those experiences, I benefited from our first class and excellent healthcare system, from the North Fork all the way to Buffalo, and how lucky we are. I'm also incredibly lucky on this Halloween to have these 2 who I'm coming home to later today. They're in our neighborhood. We get a tremendous number of trick-or-treaters, and I'm expecting over 1,200 after I leave our event. Where I wanted to I was thinking about like how to kick off this this day, and I always like to kind of start off with a story that takes us out of sometimes our quite weedy conversations that we can get in. And so I've been reading a fair amount about history lately, and I thought one example that I just wanted to kind of put in the back of your minds before we get to our esteemed panel today is our American interstate highway system. When we first started out in the 1950s, 1940s, 1950s, we didn't have the benefit of being able to get from place to place easily. And we had to rely on really fragmented roads, patchwork of existing roads, mix of paved and unpaved roads, old bridges, and narrow passageways. And Eisenhower was tasked to do a current state assessment and really help set a vision for where we want to go from here. He looked and kind of pulled from his experience in World War II, really looking at what they had in Germany from centralized leadership to set the roads, the basic infrastructure of our system up to work well. And he worked with Congress to ultimately pass a grand plan, obligating $50 billion of federal highway funds over 10 years. That's around $650 billion today, to develop a vast system of interconnected highways across our country, which we now benefit from today. In making the case, he cited four things. He cited safety, 36,000 fatalities at that point per year. He cited the physical condition of the current infrastructure, the impact on costs to the economy, as well as the individuals. He cited the economic and demographic imperative, how we are as a growing country, how we are now as an aging country. Are we equipped to actually handle what's to come? And he cited national security. In that case, he was really thinking about and made the case, if a nuclear weapon were to threaten one of our major cities, how quickly could we get out? No, not quick enough. I say all this with the reflection that we just lost 1 million people in this country to a pandemic, which we were ill prepared to respond to. We're making progress. The interstate highway system, 48,000 miles in distance, was completed after 3 decades. Change and reform takes time. It also takes vision and leadership and a community willing to have the ambition to keep pressing. And I'm really I feel privileged to have the conversation today around how we continue to press in our ecosystem for better health information exchange. Is it going to be the answer to everything that we've been hoping for? No, it's not. I mean, but it is another step forward, and I'm really looking forward to talking with our QHINs today about how they actually help us to move forward. I had a few slides, but for the sake of time, to introduce the QHINs, and especially given that we've, I think, covered this ground, thanks to David and Zoe and Virginia, I'm going to tick through. But ultimately, QHINs are large health information networks that are volunteering to support as a backbone for network connectivity across our country to support TEFCA-based exchange. Each QHIN represents dozens or even hundreds of health systems, health information networks, federal care providers, public health agencies, payers, and health IT vendors. And in New York, it's a particularly interesting situation to think about the role of the QHIN. In our last panel, we started, I don't think it was actually stated, but I mean, we started talking about like nesting networks within networks within networks in the hope of ultimately getting to a complete picture. And now we have to also to face the challenge of within that nesting upon nesting upon nesting, it can result in a heck of a lot of information coming to us, and not all of it can be useful. And in fact, that volume of information can prove to be existentially challenging. So as we talk to our QHINs today, I would ask you to think about the questions that you have for them. And how does this all fit together in New York, where we already have a pretty mature and comprehensive, albeit regional, presently, HIE infrastructure? How do these national reforms, and specifically our QHINs, align with and address our health information gaps of our facilities and plans, many of whom in this room support? How do they address our patient privacy priorities, if at all? So I'm going to introduce our panelists today. But as a reminder, I believe we have 7 QHINs: eHealth Exchange, Epic Nexus, Health Gorilla, Kanza, MedAllies, CommonWell, Health Alliance, and No2 joined the pack in February 2024. And I'm looking at Zoe here for a gut check. Our candidate QHIN, SureScript, NextGen, US QHIN.
No.
Okay.
No.
Okay. Who's
Scripts of clinical works.
perfect? And then Oracle announced this week to apply to become a QHIN. I'm going to ask our QHINs to come up in this order to share for about 5 minutes their elevator pitch to all of you. But before I introduce them one at a time, I do want to provide a little bit of background about each of them. A. John Blair has been Chief Executive Officer at MedAllies since its inception in 2001. Dr. Blair is a healthcare and technology executive with broad experience across the healthcare industry, including clinical practice, hospital planning, and governance, like a heck of a lot of experience. Prior to establishing MedAllies, Dr. Blair worked as a general surgeon for 20 years before becoming president of the Taconic Independent Practice Association, a network of over 5,000 physician members. Through Dr. Blair's leadership, TIPO was at the national forefront of transforming healthcare delivery by implementing and ensuring the adoption of the meaningful use of health IT and pay-for-performance incentives. Paul Weiler, sitting up in the back right now, who I think many of us know well, Executive Director, CommonWell Health Alliance. Paul is leading the organization into a new chapter, empowering clinicians, practitioners, individuals nationwide with interoperability services. For CommonWell, Paul was Vice President of Strategy and Business Development for Philips Interoperability Solutions. He also spent nearly a decade at NICE as Chief Information Officer, VP of Product Management, and Program Director for the Regional Extension Center. He knows New York well. Nahit Bajaj, a solution specialist at Epic. Nahit is an interoperability lead at Epic, helping customers support care everywhere. Epic's interoperability platform for patient record exchange. Additionally, within the industry, Nahit serves on Care Quality's Advisory Council and is on the Sequoia International Interoperability Matters Steering Committee. And then finally, Steve Yaskin, last but not least, CEO of Health Gorilla. Yaskin co-founded Health Gorilla in 2014 and has led the company through 3 strategic funding rounds, including a $50 million Series C round in March 2022. Before Health Gorilla, he was CTO for Elite Medical Center, a provider organization specializing in primary care and geriatrics that served more than 50,000 active primary care and chronic disease management patients. He has a long-standing history in the technology and digital health space, and closes out our four-person panel for today. I'm going to ask John to come up and provide a few words on MedAllies, 5 minutes, and for each person, we're asking if they could provide an overview of their QHIN, including distinct services and membership, and a real example, if possible, of how someone's onboarded and benefited from the service. John.
Can everybody hear me? Yes. Okay. Paul, did you ever think we would be called the new kids on the block? I think that's what we were, right?
Some question.
Yeah. All right. I don't think I have an elevator pitch, and I think I would be loath to try to stand up in front of my competitors and pick them apart and fan our flames. But I'll tell you a little bit about my background. A lot of what these QHINs do are the same as we've heard, because by design, the technology in the middle is essentially identical. We go through a very rigorous process on the conformance testing to become a QHIN. Those two candidates right now are probably suffering through it right now for on their way to designation. But anyway, I just want to give a little bit of background about myself. You mentioned Taconic IPA, so I just have to bring that up because it just was north of here where this all really started. And then I don't know if anybody remembers Think Rio. That was part of what I put together with Lori Evans in the day. And then I'll get to Med Allies and a couple of things about Med Allies that I think are important to understand. And it's not that the other QHINs don't do that. Some probably do and some don't. But for me, started out in academic medicine, came up to the Hudson Valley and was in a surgical group, ultimately became the president of Taconic IPA up in the Hudson Valley, 5,000 doctors. And from that, with our frustration on coordination of care and improving care, we started a little company, or I started a little company called Med Allies that was strictly for the purpose of getting coordination of care amongst the doctors as they came up on electronic health records. And we heard about comments about HEAL 1, 2, whatever. I think Rio was the recipient of probably maybe all but one of the HEAL grants. So that was kind of our initial venture capital, I guess, for the region to build out all the things we did. But ultimately, Med Allies went through electronic health record implementation, several thousand providers in the region. So we know that well. We were part of NCQA's patient-centered medical home and the development of that. And at one time had the highest level of, or highest number of level 3 patient-centered medical homes in the country. So we really understand the workflow and the importance of all of that. At the end of the day, at least for providers, data can flow all over, but if it's not usable and well built into the workflow, it's irrelevant and not used. So we understand that. And I do think that brings a little bit of uniqueness because we were started with clinicians that came from multiple care settings. And today, even though all we do is move the data, we understand the importance at the end of it for the users. Anyway, Med Allies did all that. We ultimately got focused on interoperability. We were very involved in the direct project as it came about and were early on a national direct network. We still do direct secure messaging, have probably close to 150,000 providers on our direct network. So we understand the business of running a national network. And Paul's probably tired of hearing me say this, but technology is only a piece of this. And to do this well, you need, I believe, close to an equal investment in the professional services and the operational side of this around onboarding, around support, around working with these vendors, how they implement this so they build this properly into their workflow and usability. So Med Allies, if it distinguishes itself in any way, is that because we have never let that go. And that has carried on as we became a care quality implementer. We did that in the lead up of becoming a designated QHIN. We were one of the original. It's been a little bit under a year that we've been doing this. We heard from Zoe and others how difficult this is. We're really doing something that's trying to coalesce many of these national networks. One on-ramp that was that people are looking for, that was mentioned, one connection to everything. I don't know if I'll see that in my lifetime, but I do think you will see a coalescing of many of these networks to get you to one on-ramp for one type of network. I don't think HIEs will go away. I think they're part of this. I think, again, they'll probably move more and more from just connectivity and data and moving data to what we've heard about with analytics and all of those other pieces with data and the utility. So Med Allies, as a QHIN, is doing what all the other QHINs do. We are moving data from its site of origin to the requester. So we all do that. There's a different flavor. Some hold that in the middle and are able to do a lot more with the data in terms of longitudinal records, analytics and stuff, kind of more like national HIE. Others are purely a conduit. We're a little bit of both. We are strictly a conduit. However, we have that capacity on the edge for different types of stakeholder groups to do things with the data, dedupe it, clean it up, do analytics on it, do reporting for it. And that more plays to payers and other entities that we're contracting with. And then others just want the data from its site of origin brought to it to bring that together, that organization themselves. So it varies with provider or with different stakeholder groups. We try to meet both of those. You asked about some of our, I've got 1 minute now. Okay, you asked about some of, we are dealing with treatment. We have EHR vendors and have brought on a couple of those products in the last year. We have individual access service, consumer facing platforms. There's a company called Selfie that went live on our care quality network that's going live on our QHIN. And then we also have payer facing companies. Some may be familiar with DataVant, recent company that's contracted with us that will be taking the data, and they're a request of information company. So, we have all of those types of companies. And just one thing you asked about what we do in terms of an organization, how they may onboard or something. I'll take Veradigm EHR is connected to us. And what we've done with them is through a gateway built into their 2024 version. So that's going to be fully, they redo their version every year. So by the end of this year, we will be connected to those 1,500 practices and 16,000 providers. So they already have our network, already have it. And we've gone through some automation tools so that if a provider organization decides they want to be activated, they flip on what's necessary for the functionality and the software, bring that group on in 2 days. So we can bring those on very quickly. And that's just an example of what we've done. Thank you.
Terrific. Thank you so much.
You want us to sit up here when we're done, or?
No, you can go.
Okay.
Paul, where you at?
Here.
Okay.
No, maybe, kid not.
Yeah, I'm kidding. No fun.
He got a clip-on thing. I think that's unfair. It's all good. Good. Are we still morning? I'm so confused. I was in Australia last week. I don't know what time zone we're in any longer. They actually don't switch daylight saving the same time either. So like things go really wacky. Your calendar goes berserk. It was impossible to keep up meetings. Good morning. Paul Wilder. I'm with CommonWell now. As was mentioned earlier, fairly long history in New York State doing good, bad, or indifferent things relative to interop. Used to run, well, actually my staff and myself designed the shiny architecture we have today relative to the QEs connecting. Actually very similar architecture to CommonWell, right? It is a gateway of gateway approaches with a master index above it to help coordinate what you can see across the various entities. So if you look in New York, you have Rochester. If they are looking for data, they don't say, I want data from Buffalo. They say, hey, nice. Who else has this same patient somewhere in New York? And they say, well, Buffalo and Healthix have something too. Oh, okay, I'll go get data from those two and suck it in and do what I need to do, normalize it, health data utility stuff, all the stuff we're going to do. The real power here is in knowing where the data is, right? So we talk about trust and community at scale at CommonWell. And to give you an idea of scale, we are structured a little differently than the way HIEs are traditionally structured, that our primary members are vendors. So our primary members are going to be health information technology vendors, particularly electronic health record vendors. So Athena, eClinicalWorks, Oracle/Cerner, whatever history lesson you want to go from there. And that balloons out pretty quick. So we only have, I think it's 42 active connections to our network, but we're connected to gateways. So that leads up to 37,000 clinical sites, right? And actually, we think that number is low because Oracle is underreporting the facilities underneath their connections So some of those are IDNs that fan out even bigger. So it's a lot of scale really fast. It's about 500 million documents a month flying around, both inside our network and then through other frameworks we can include. So when we think of TEFCA and what we're doing, TEFCA was a natural extension of what we do, just as connecting to care quality was, right? So care quality, which, Epic is one of the founding members, I think he's here somewhere, right? Yeah, there he is a framework of connections, and we built a bridge over to there, and now we're building a framework for connections under the TEFCA paradigm. Why the switch? It's a great question. We'll talk about that a little bit probably in the panel, but I'll finish the thing about CommonWell. So we are really designed for doing these at scale. We actually do have HIE participants, interestingly, one from New York even. So, we're proud to have that. Our architecture is designed around a record location system. Now, what's record location? Read the words. Where are the records located, right? They're located here, here, and here. That does not mean I know what's in those records. So part of the trust framework here, and that's the second part of our network, is a contractual trust framework that, providers will provide data. They will also have the right then to get data. And this analogy doesn't work all over the country. It tends to work in the Northeast. Most people here have heard of potlucks, right? If you think about potluck, it's often attached to like a charity event or something, right? You got to buy a plate, but you also got to bring an entree or an appetizer to share with others there. And so when you think of interop, the reciprocity, the data sharing, a lot of it has to do with that. I agree, I will share my data. In exchange, I also get data. So while they pay to be part of CommonWell to get the base functionality established, the real cost, the real currency is the data going back and forth. And it's equalized by I can get data and I give data. So just like a potluck, I have to buy the plate to support the charity, but I still got to bring the entree that everybody's going to take from me. Right. So it's, it does cost money to run this stuff. We're a nonprofit, just to make that clear. We're actually a 501c6, which a lot of people don't know. So we're a trade association. And if you think about what I said, my structure is our primary members are vendors. So we're a trade association. We represent what trade and the marketplace needs. And when we formed, this is 2013, what was needed was what we thought, or at least our members thought, was for the members to get out of the way of thinking they will control interop and the data exchange that happens after that. The belief was no vendor is a single vendor solution, a single solution for everything. We needed to connect together, and that we needed a coordinating traffic cop, both contractually, so that's the trust framework, and the technology of the record locator system and the MPI. But it is, to be very clear, and this is very similar to what John just said, we're one of the QHINs that doesn't store any data, right? Actually, that's not true. We store identifiable data, right? You ask me where Paul is, I tell you where Paul is. So I must know who Paul is in the first place, right? So we have personal identifiable information. We don't store any clinical data. You could ask me, I guess, what are the percentage of male versus female patients in the United States? I probably know that. If you ask me how many diabetics, I don't have a clue. And I'm not going to go purge and pull 250 million patients. Like we have 253 million persons in our index right now. That balloons out to about 950 million individual patient records. We're not going to pull all those to get that answer. So as we advance, you look at TEFCA, you look at new use cases. We're very excited with the new use cases. I will say some of them don't really line up as well in a query-based exchange network, and we have some work to do. Particularly like you look at public health, which tends to be a reporting thing, not a query thing. But you don't find out how much malaria is popping up in the country by querying all 850 million of my records every hour, right? That's not the way you do that. So, there's more to do than just what TEFCA starts out with. There is a push technology embedded, and I guess we'll talk a little bit as we go. Thank you.
Thank you. And next we'll hear from Nahid from Epic. Alana.
Hey folks, I'm probably the newest kid on the block here, so happy to be here. I'm here to talk about Epic Nexus. I think most of the folks here know who Epic is. Epic is a EHR vendor. We help serve our community across the nation. And our Nexus is our QHIN product that's designed specifically for users using Epic. It's designed to help streamline interoperability, but really focus on the end user workflows. So the user has no recollection or even understanding that they're exchanging through TEFCA versus any other data exchange that'd be happening. So we're really focused on helping our physicians be able to benefit from getting external data for patients, treating the patients well, without realizing what's happening in the back end. We have heard a lot here today about TEFCA adoption and what it means and where we're going and the train that's moving. At Epic, we have bias towards action. When we are committing to certain things and we're saying certain things, we want to actually be able to produce results. And one of the things that we've been sharing publicly, and I'm going to reiterate and share that, is our goal and our hope is to get all of our Epic community live on TEFCA end of next year. And we do that because, or we're sharing that because we really do find value in TEFCA that supersedes what exists today in the current interoperability frameworks. I'll talk more about that afterwards, but we do see the benefit in having ASTP oversight, the sponsorship in TEFCA, the comfort it provides our healthcare organizations, compliance teams to know that the data that's being exchanged is being done for the appropriate reasons. I want to share this cool fact with everyone. So today we have 79 healthcare organizations across the country live on TEFCA, live. That comprise of 736 hospitals and 9,888 clinics. And on top of that, we have 105 in other organizations that have already reviewed and signed on to the agreement, are in the process of implementing turning on TEFCA. So we're already making a lot of really good, meaningful progress here. 10 New York organizations have actually pledged to join TEFCA, and we had some preliminary conversations with them, and they understand what it means. So again, I think I want to reiterate and share, TEFCA is real. It's happening already today. I think we kind of hear a lot about when TEFCA was first explained, is the TEFCA's goal is to help close the gap in care that exists today. Even in treatment, I think a lot of times people are thinking about the other use cases, which is really important, but in treatment, there were, I think, estimated around 20 to 30% of hospitals that weren't connected. So meaning if a patient was seen at that hospital that maybe you know about, you're still not able to pull data today through the current interoperability frameworks. And the goal for TEFCA is to help close those gaps in care, to get everyone on board. We were one of the first group of QHINs to connect to TEFCA, and we actually were part of that first exchange that happened with TEFCA, so we're really excited about that. But we wanted to dive into that little bit of gaps in care metric and see what does that actually mean. I'm a numbers person, I think. I look for math to back up the conjectures I make. And so we did some assessment and found that today we have had our Epic organizations through Epic Nexus have exchanged over 2 million patient records through TEFCA that they wouldn't have gotten in any other interoperability framework today. So these are net new connections with hospitals and clinics for treatment that we're able to close that gap in care because these organizations joined TEFCA. That again is value add for them. We think this is powerful. We think obviously in order for TEFCA to succeed and be successful, everyone needs to join. And so hence we keep reiterating the importance of joining and doing it appropriately. And we're hopeful that others, not only Epic, but other vendors will also start to onboard their clinics quickly. I was going to give a quick example of what that onboarding process looks like as part of the overview. And I think it's interesting because I was just talking to an organization that onboarded just last week. I think the longest part of an onboarding process, if you're interested in joining TEFCA, is actually the QHIN participation agreement. That requires a lot of the review to make sure not only do you understand what it means to join TEFCA for treatment and other purpose of uses, but also a lot of times organizations that have an EHR instance extend that EHR instance to other subgroups. And so they're likely going to be your sub-participants. So you need to ensure that your sub-participants knows the relevant terms and understand and can comply to it. And that process taking the longest is a good thing. It being the right thing to do, everyone's aware of what it means to join TEFCA, what it requires, is foundational to anything else that you do within the framework. The actual technical implementation takes hours. We had a group who actually went live on TEFCA a week after they were done signing their agreement through their entire change control processes, having multiple hospitals, multiple organizations go live. And they actually also, as part of their TEFCA onboarding, went live on electronic case reporting that we talked about, essentially reporting to public health agencies that they hadn't done previously. So again, joining TEFCA to them and many others was a net new added benefit that they didn't have today. So again, excited to talk about a lot of other topics here, but wanted to make sure you all knew about Epic and Epic Nexus, our mission, our vision, and ensure that you know what we hope to accomplish through TEFCA. Thanks.
Okay, last but not least, where's Steve? Okay, here we are. Really nice to see you. And then, so after this, I'm going to ask all of our panelists to come back up, sit over here really closely. And then I'm going to ask 3 or 4 questions, and then I'm going to open it up to you guys for the questions that you have for our panelists today.
Good, thanks.
Yep.
I'm Steve Yaskin, CEO, co-founder of Health Gorilla. I'm also one of the new kids on the block, and I would say very honored to be in a company of John, Paul, and others that spent decades in the field. So we decided to bring kind of Silicon Valley mentality and technology advances into the fray. I still remember a couple of years ago. First of all, about myself, I grew up in New York, and I moved to Silicon Valley, gosh, about 20 years ago, where they tried to remove Brooklyn out of me unsuccessfully. They failed. They kind of failed at that. So I brought Brooklyn to Silicon Valley, and I'm back here to try and make change into interoperability space. My heart is in New York. Sorry, Yankees fan. I'm kind of torn because I live in California, but also major fan of Yankees. So I was watching the game on a plane yesterday, had my iPad, and had like 10 people gathered around me on a plane watching the game because I had Wi-Fi. For some reason, nobody else had. Health Gorilla started a couple of years ago, and I still remember when I had this original vision, how we can bring technology advances into the realm of interoperability. I had a lunch with Marianne from Sequoia, and I presented my case, how we could bring technology and innovation and what we can focus on. And she said, well, Steve, this is all great, but you need governance, right? You need adult supervision into that. So we spent the next couple of years building an executive teams comprised with some of the industry veterans from interop field that actually created governance. And somebody said TEFCA without T is just TEFCA. I actually really like that field, but I think governance, technology without governance in this field is also very dangerous, as we've all watched some of the recent events, how trust got eroded, and we're trying to build it back. Right now, using the QHIN designation. Health Gorilla was also one of the first QHINs that actually live exchanged data in December of last year with several other QHIN participants. We were very proud to be there, but we also spent a lot of time working with the states. We've done a lot of work in Puerto Rico with all the challenges that Puerto Rico presents. We got disrupted several times by various hurricanes and other events happening in Puerto Rico, especially the last one kind of put a big reset for the whole island, but we're still working there, still very active. And we did the same in California. So California has a very similar program to TEFCA called DXF, Data Exchange Framework. And, you know, California likes to do things in their own way. They take federal regulations and Californize them, for lack of a better term. New York is kind of similar. They have very, you know, unique state laws here. Very interesting environment, but Health Gorilla is the only QHIN that qualified as a QHIN on the federal level and also qualified as a QHIO in California. And we find ourselves in a very interesting mix. First of all, we're Silicon Valley companies, so I have a board of operators, and I have to get my marching orders from SOPs from RCE. So it's kind of weird situation, but we're making it work somehow. Governance, technology on the governance, what does it mean? Health Gorilla is focusing on several key components. Universal adapter, record locator service. We spent years building our RLS. Data normalization engine. We speak 120 different healthcare languages from CCDA, HL7, all kinds of transactions, mapping this out, converting into FHIR. We support several models. We're pass-through, we federated, but we also aggregate data for analytical purposes. We're very open about it, so we do have a thin data lake layer that we use for analytics and performance and other secondary data usages. Health Gorilla serves digital health primarily. Vendors, Health Gorilla serves ACOs. We also have payer contracts nationally. Health Gorilla, by the way, started with labs. We build our own labs diagnostic network, which we are happily sharing with the rest of the QHIN participants and Care Quality and CommonWell networks. And recently we started working with the EHRs, anybody whose name is not 4 letters starting with E. We're working with pretty large acute EMRs like Meditech recently switched, adopted Health Gorilla QHIN, ResMed, Matrix Care. So we focus a lot on home health, Canvas, Dr. Corona, and many other ambulatory EHRs as well. As a QHIN, I think we invest a lot in our compliance governance, but also being able to support all 6 permitted purposes as we get SOPs. We participate in a lot of feedback we supply. And our commitment to the QHIN market, to TEFCA in general, is that we will be kind of on the bleeding edge of bringing technology to empower each of the permitted purposes as they get adopted. Health Gorilla is a neutral player, which kind of sets us apart a little bit. So we have our own niche. We are not in the EHR. We didn't come out from EHR. We're not in the HAE, but we are a purpose-driven QHIN. We were created as QHIN, and that allows us to be a lot faster in development cycles. That's it. Thank you very much.
Okay, so I think we have time, maybe a couple of questions, and then we'll go to the audience. Okay. So it's so great to see you guys, like all up here. And Paul, I'm going to ask you a question that you asked the audience at Civitas a couple of weeks ago. You asked, everyone should ask, how does a QHIN help me? And I think that's a question this audience would be really interested in hearing an answer to. And so I'd love, if you want to kick us off and then we can go down the line, I'd love a thought from everyone. How does a QHIN help me?
I wish I knew. Well, it depends, right? So when we talked about, John actually mentioned, and I'll steal from a little bit, that there's some equalization of the QHINs to some extent, but that's really at the edge, right? So if you have a phone, what you want to be able to do is call any phone number, right? You don't want to have to say, is this person on AT&T or are they on Verizon? Do I have a bridge across from that? Like, for the elder statesmen of the room, including myself, when it comes to IT, there was a day where we had like things like Prodigy and CompuServe, and we had these, siloed email systems, and they did not connect. And you could send your friends a CompuServe message, but you better have Prodigy too if they're on it. And at some point they bridged. And the QHINs are designed to help make that bridge work, right? How they work on the inside could change a lot, right? Some are going to be fan-in, some are going to have an RLS it's precise. They're going to have different services. But at the edge, the technology is going to be the same. Very similar, by the way, to, and of course you use the analogy, so I'll amplify it to the highway system. I got news for you. New Jersey, I live in New Jersey. You show a Georgia person our jug handle thing, and they think we're absolutely bonkers, right? Like they're like, we're like, well, this is how you make more efficient right-hand turns, and we'll swear by it. But the freeway system is consistent, right? The signs are on the right, right? The green signs are there. Sometimes they're above, but they can't be on the divide on the left, right? There's certain things that have to be consistent for us to be able to have a system that connects things together. And the QHINs have a set of protocols, standards, and trust requirements that allow us to connect to each other. And then you have the stuff that goes on the inside. So when it comes to CommonWell, it's almost more of a question to our EHR partners, right? We believe that the workflow of interop needs to be as embedded as possible in the workflow, the productivity tool you use all day. Right? The equivalent I give, my productivity tool, but whether good, bad, or indifferent, is Outlook. It's email. Most of my time is spent there. If you pulled the calendar system of Outlook or Office 365 or pulled it out of Gmail and disconnected it from email, I would cry, right? Because it's so much of the time is spent with meeting adjudication and invites and forwards, things with dealing with people and managing people and the content that goes around that. It's not just an email system. So you think about your EHR, the same thing. It's got practice management, it's got clinicals, it's got all this stuff. Interop being outside of that doesn't fit our DNA. Now, HIEs are different. HIEs are often just slightly adjunct. They might have OAuth, credential flow to be able to go from in context from an EHR to out. But our primary member is going to be something that's embedded the technology. So we don't produce as much normalization stuff that a Health Gorilla does or the like. We're a little bit more of a fire hose because we expect the EHR to normalize it the way their data standards work once they get the data embedded to their side. So it's a question many times to the individual participant, Oracle, eClinicalWorks, et cetera, on our side of what do I get when I connect this interop stuff? And right now, that is a debate, right? Sometimes it's too much data. I'll stop there because I can go on for about 42 minutes if you want.
Dave, John, anything to add?
Well, I think you need to call out which stakeholder group you're talking about because it's different. We talk about, holding data in the middle versus a conduit. We didn't do in the middle because 2 or 3 of our very large potential customers said, you do that, we're not going to do this. So that just made the decision for us out of the gate. So you have some of the customers that don't want that at all, that don't want the original data coming to them as widely as you can bring it in. And that gets into your record locator service piece and who's going to be able to get the most back for you. That's one thing. But then you go to a clinical, an EHR vendor and a clinician who says, well, 10 CCDs, what am I going to do with that? That's overwhelming. So we've built the capability of our platform to do some level of duplication, normalization, and create a summary view from what comes back for those clinical people. If you look at, the health plan facing thing, you've got to even go further than that with it. So again, it depends on the customer you're catering to and how broad you want to go to get to those different customers. If you try to do everything for everybody, you can't do it. So, we've got 3 or 4 categories that we're catering to, and, so that's where that is.
I can go next.
Yeah.
I think it's harder for us, right? Because we're not essentially competing in the same marketplace from QHIN valuation. I think for us, what we focus on is recognizing that it is intimidating and complex when we talk to our healthcare organizations about joining TEFCA. They see the SOPs, they see what's all on the website. And our role as a QHIN becomes simplifying it for them, helping them understand what it actually means to connect, helping create tools to help them understand what are their physical locations that they should help enter into the directory as part of the TEFCA requirements. And so as a QHIN, we become a conduit for them, the relationship to help them get on in the interoperability on-ramp. And I think that's what we see as our number 1 priority. And then number 2, I think once you're live, a lot of times organizations tell us it's hard to get the help I need because I'm connected, but I'm not able to see the chart from this other hospital that the patient went to that's down the street. And I think our role, because we understand the EHR well, we understand how the data is displayed, we understand the configuration, we're able to help better serve and support our users by knowing how the data comes in and how the data flows out, and also what we expect to see done in the EHR. So really focus on the user experience.
Steve, anything to add?
Yeah, I want to echo that a little bit, what Nikhil said. It's in a lot of these cases, we do a lot of work collectively as QHINs. Don't mind the man behind the curtain kind of thing, right? We focus a lot on data cleaning, data quality. MPI took us 5 years to build meaningful MPI that could stand up to what other QHINs are offering on the market there. But I similar to John, I built one of the largest IPAs, primary care, internal medicine in Bay Area, and at the end of the day, when I, talk to those doctors sitting in front of the computer, at the end of the day, they do not care about I know this. All they care is what they're looking at on right there on the screen. And from previous experiences, especially in the primary care, it's kind of a front French in the war. All they care about, can I see that record in 30 seconds that I have? Patient is coming in, I've never seen that patient before. So to me, UX was one of the major differentiators, is how we build the QHINs, which culminates in a screen, in the real estate. And of course, this is where you start having all those challenges, because physicians, while they enjoy easier workflows, they want to be in one system, and that's always an EHR, and it's always a system of the record. So to me, that QHIN opened up that path to collaborate with the EHRs, with digital health vendors, with bespoke EHRs. There are a lot of value-based care providers now do, and embed ourselves into those workflow processes, but also surface the data in a meaningful way to providers at the end of the day, so they can, instead of seeing 5,000 documents, which is what previous networks used to do, and everybody kind of got used to that, see a comprehensive and actionable view of that patient in 30 seconds. That's all that we got.
You mentioned like reconciling patient identities, like a major role. And this is actually a question from someone out there in the interwebs who's we have, I think, twice the size of the audience out there listening to us today, which is tremendous. Receiving and reconciling patient identities across the nation must be daunting. How do you approach that and approach it well? I'm going to open this to anyone who wants to take this question. Okay.
Well, first of all, there was a question asked in the earlier panel as well about kind of the DMV and the driver's license, and we often do the perfection enemy of the good problem pops up all the time, right? There's a significant amount of stuff that's actually relatively easy to match as long as people are paying attention, right? And I think there was years where we weren't paying attention because we didn't care about interop. You go back 15 years ago, thinking about the one of the lowest paid people in the hospital, and I'm sorry if I'm offending anybody, is that front desk registrar. That person right there is in charge of a significant amount of your interoperability capabilities, right? They type that in wrong, it's over, right? If they don't check the ID and see that that doesn't match the insurance ID, we have fraud problems, right? There's a lot of stuff that goes on right at that desk, and we forget about that downstream. One of the things that we did that CommonWell does, this is a difference across the QHINs, and I'm not saying good, bad, or indifferent. We actually started out with no automated matching whatsoever for patient identity. What happened was inside of the workflows, we're talking about in the EHR, we had APIs that called into the MPI, into the master patient index or master person index, and said, give me suggestions on people that might be the same person sitting in front of me right now. And across the country, people were adjudicating those. That is the same person because I can interrogate. I can kind of say, where'd you live other than New York? I lived in Illinois. What city? Evanston. Main Street? Yep, that's you, right? And so they would confirm things. Now we've moved to more automation. We do have MPIs that do normal matching stuff, but 80% of our links up until basically beginning of this year were based upon manual links, and that still led to 350 million matched records. So you do have to think about now, in an HIE sense, it's different. You tend to have staff at the HIE that do this. So you start out with an MPI with probabilistic matching, which David mentioned. You then put on referential matching, and then you have another queue of X number of people sit there looking at these near matches and deciding what to do. We just broadened that out as part of our trust framework of, it's not just trust of I give you data, you give data, but we trust each other to help make the MPI work better over time.
Any other quick additions?
Mine was a long addition.
I'll just add a quick addition. I think patient matching is obviously very, very critical and important. But when we talk to our organizations, they tell us that the patient medical record goes well beyond what's in the wall of work or what they're seeing at the clinic. And the external data is so much part of the patient's treatment. And when that data is wrong, meaning when you have the wrong patient record or listed in the current patient's record through external means, it can have very damaging impact. And so it is concerning, right? It's concerns to make sure that identity matching gets done well. So you're actually matching patients, but done it with the right patient at the right time. And so what we've done to help with that in the past and continue to do is we worked a lot of stakeholders in the past and have made some specific criteria to what we think qualifies as good standards for patient matching algorithm. And we recognize that the patient matching algorithm isn't really just an Epic problem. It has to work across the board in the industry. And so as our work with Sequoia and Care Quality, we actually published our standards and guidelines for other vendors to know and recognize. So they could essentially either benefit or adjust their own algorithms based on our findings. But yeah, we think it's really important to get done right, but can be very damaging if done wrong.
32nd edition. We shared the same concerns, the same visions, and our response to MPI. I mean, if you think about it for a second, HE's have really been doing that for decades at the local level. And as new kids on the block, we had to get really fast to the same level of quality on MPI, but do it nationally. So the volumes and the scales are a lot broader, and the cost of the mistakes, because sometimes we are not presented for manual verification, like CommonWell has that huge advantage. The cost of a mistake is enormous here. So we had to absolutely make sure it's bulletproof. And the answer to Health Gorilla's MPI, several years of development, was just to bring more external referential data. We also use probabilistic matching. We do not use AI for that at all, zero, until such time that it makes sense to do so. But we do bring tons of referential data from credit bureaus, from experience, from many other external data sources to enrich. Hydrate the data was the term David used, I think. I really use that term all the time. And the more data you have, the better criteria for the algorithm that you set and share with others, it becomes more precise.
Yeah. So John, I'm going to come to you next.
Well, I just want to say one.
Yeah.
I mean, not all of us. Not all of us have probably invested as much as some, but I think this group here has put a lot into our EMPI, and we've invested a tremendous amount into that. Paul's actually looked a little under the hood at ours. But the short of a bake-off, I don't know how in the world, other than us talking about it, you're really going to know. And I don't know how we're going to get a bake-off to see who can bring in the most records. But anyway, I think the short answer is there's been a lot put into these EMPIs.
Yeah.
Anyway.
So I always rely upon you to ground us in the reality of like what's going on. We've talked a lot about today, like the good things about QHINs, like how we're starting to fill gaps with this, with TEFCA and its implementation across the country. Talk to us a little bit about the realities of implementation, things that folks will see. You mentioned duplicate records. Like how can those be mitigated or avoided? How can we make sure that we're integrating this like QHINs into our clinical data flows, into our decision making in a way that makes a difference? And then I'm going to turn to all of you for a couple of questions from the audience before we go to lunch.
Yeah, I mean, a lot of that's going to fall to, I mean, at least for the clinicians, is going to fall to the EHRs. I mean, we can get them the data, but they're going to have to do something with it to make it more improve upon it. Now, there is a project out of Sequoia, data usability project that's been going on for several years. I think they're putting out their second version for their implementation guide, and then they have a subsequent thing called Taking Roots, which is actually implementing it. Maybe everybody here is part of that. I don't know. We are involved in that, in both the usability and the Taking Roots group, and have built that. I talked about, again, we don't hold the data in the middle, but to the degree that a participant wants us to do something with it, we have that ability at the edge to standardize it, dedupe it and everything. And we are following to the T and have implemented that data usability IG. So, I mean, that's one thing that we've done about that to improve it. I will say this because Zoe brought it up later or earlier, and we've all been suffering through this for the last last month, I think. But one of the problems with these national networks and the trust has been, when you're bringing on or different potentially bad actors that are doing things or saying they're doing things that they're not. And there's been so I think there's going to be much less risk of that with TEFCA, because that would be a problem, wouldn't it? If you're giving up your data providers, the data sources, and it was going somewhere that was not intended. So there's been a ton of work to improve that. Anyway.
Terrific. Final comment, and then we're going to go for questions.
Really quick on the data usability. Totally agree with John here. We're a big proponent of data usability work from Sequoia and have done the taking root action. I'll say this, that was one of the things that our organizations actually were worried about. They recognized when they're joining TEFCA that a lot of their trading partners are already on other networks. And they said, am I now going to be retrieving data from Care Quality, eHealth Exchange, and TEFCA from the same participant? And am I going to see that's 3 different times? And we've been lucky so far. We're hopeful that this trend continues, that organizations who have onboarded these entries in multiple networks have used a consistent identifier. So we can be very intelligent when we're requesting data to say, if we're already requesting data through TEFCA, maybe not also request that same data through Care Quality, eHealth Exchange, or other framework. And I think that consistent identifiers can be a really good source of benefit from organizations to streamline as groups onboard. Additionally, we have invested a lot in our deduplication logic, just like everyone else has, but recognize that that continues to be a challenge for the industry as a whole.
Terrific. So may I grab Mike? I think you would just raise a really important point about bad actors and the importance of consent. I think David started talking about the importance of state rules, regulations, and protecting consent earlier. That could be a whole session.
I just want to pick up on that last question around EMPI. Everybody's got their own EMPI. There are 6, 7 QHINs. They all have them. SureScripts has one. Cigna. Everybody's got an EMPI, but nobody knows each other's EMPI. So within sort of a QHIN to QHIN, the whole point is exchanging data between QHIN. You've done work within your networks or organizations have an EPI, but the whole point is cross-network. So what's a model for kind of cross-network identity resolution, EMPI to EMPI?
Oh, I have to turn it on. Yeah. Technology. Just before I forget, just one thing. I'm going to answer that. One thing I'm going to add the last thing. Please, please, please. I'll say I won't say the remaining 22 pleases. I was going to add. Check the output of your own data. One of the biggest problems we see in interop is people have no idea what garbage they're spewing out because they only care what they're getting in. So before some other partner yells at you, find out if you have a normalized data set and whether you're being complete or not. It's embarrassing when you find out you just didn't pay attention to the paperwork that said which dials and switches to turn on. And like, oh, all I had to do is this and everything works fine, right? So just that. It is a very, very interesting problem right now, right? So in TEFCA, even more interesting, it doesn't actually specify you need an MPI. MPI is a voluntary thing inside a QHIN to decide if it's necessary for the way it coordinates what it does inside. You are allowed to do things like internal fan out, where I get a request for where's Paul, and I broadcast it to my entire network, wait for a response, and return back. And if you think about that, that amplifies that problem, because not only am I looking at, I could tell Med Allies, and in fact, in Care Quality, we did this. We had an exercise where we said, what's everybody's matching logic? We just gave everybody our spec and so here's what we do. Right. So if something's not matching, you might want to look here and see what's wrong. Now, what's interesting about that, though, is you don't know when you make a request what the other side data actually is. So you can see that I'm looking at first name, last name, date of birth, gender. Gender is actually a moderate problem right now, just to be honest, right? So there's birth and there's observed and there's politics involved with that too, right? So it's more difficult than it seems. Thinking about ripping it out as a criteria, actually, quite frankly. And some use social security number 4, SSN 4, all these other things go in. But when I feed you that data, I don't know if you have it, right? And the normal response in interop is yes or no. Yep. Right. It's I have that person and uniquely identified them, or no. And the no could be because the data doesn't match, or because it was ambiguous, or it could be a whole bunch of other reasons. So we do have a problem here, right? And so when we think about QHINs, and I get asked this question all the time, what about a national identifier? I'm like, hell yeah. Right. It's not, I don't want this as a differentiator. Like I would. Yeah, well. Farza gave a very colorful response to this a couple of years ago when he was head of the ONC. I can't use F-bombs here, but he got away with it in front of 1,500 people at a Medicare conference. He was just like, no, and stop bleeping asking. Like, we're not getting there. So it is still a problem. The best we can do right now is expose what our logic is and be very, very vigilant on all the support tickets, whatever, to trap this through. We find that sharing patient identities kind of one-on-one to say, this is why this happened, helps a lot. Actually, Epic and CommonWell went through about I think it was a 6-week exercise on 2 practices that there was a major matching problem. And what was the problem? The provider had just recently onboarded to CommonWell or re-onboarded to CommonWell and didn't do a backload of their MPI. So all we have is the last 18 months of identities. So all these things weren't matching that were before 18 months plus 1 day. All that stuff was dark until we brought it back again. So you find out these weird things only by looking, unfortunately, by transaction.
One last question. Okay.
Well, specifically, this question is for Dr. Blythe. I'm looking from the consumer point of view, the patient side of it. You see, actually have a doctors participating in your TEFCA. I suppose they started already using TEFCA. And are they interested in promoting consumer as patients, how to get the digital medical record from them and aggregate the data they get from the labs and other testing places, diagnostic facilities, and interact with the doctors? Are they encouraging them? Are they interested in it? Are they excited or not excited? Or they want to keep them away?
Yeah, so you're asking if the consumer facing company that is connected to our network, what kind of responses they're getting and whether the providers are comfortable giving that? Is that what you're asking?
Yes.
Okay. They're not. So this is individual access service, and you may want to speak to this because this gets to the provider's comfort in giving the data out to a non-provider, and how can they trust that it's going to the right patient, and if it's not, will they be in trouble for a breach? So there's a lot of concern around that. There is less concern as we move to FHIR. You've heard about FHIR because there's going to be a standard that will have to be utilized by 2026 that gets into the registration, authorization, and access. It's called UDAP, and others here that understand it better than I do. But once that gets in place, I think that things will improve. But that's a little over a year from now. Epic is doing something to satisfy their providers that goes a little beyond what's required under TEFCA. We're working with them on that. That company that I talked about is going to make that compliant. But again, it's the provider organizations that feel comfortable allowing this for a non-treatment purpose. I mean, you want to follow on that at all?
Yeah. Final quick thoughts here?
Yeah, I think you hit the nail on the head, right? I mean, apps are not covered entities. And so when providers have to disclose data to non-covered entities, there are concerns from the compliance teams. And so I think TEFCA does have some advantages where these apps sign on to agreements that get them to follow the guidelines for the covered entities. It still depends on who you're talking from the compliance perspective. I think to John's point, there are some more recent advances in the individual access IG implementation guide that allows patient control to release their data through a portal. So for our example, patients can now go into My Chart and be able to say, yes, I'm authorizing Apple Health or this other entity to release my data. So there's a sense of security that the right patient's being matched, and it allows covered entities a little bit more comfort.
Yeah.
Steve, closing thought?
Yeah, I think IAS is one of the most exciting, most visible, most talked about things that TEFCA enables. Actually, we probably still too early in IAS adoption, but I noticed from my experience there are 2 types of people that don't care about their clinical data at all. Younger people that tend to be more healthier can care less whether or not they have their Fitbits and stuff like that, how many steps they walked. There are also differences between corporate physicians, employed physicians, large health systems, and ambulatory physicians, right? Obviously, there's a tiny minority of ambulatory physicians that operate clinics and things of that nature. Depending on state, they're a lot more interested in sharing data with the patients than larger health organizations where rules are very different from that. So using those guidelines, we hear different levels of feedback. We absolutely need data and we don't really care whether or not we share this data with patients. But I think TEFCA is at least designed on the right track with the IL-2 measures in place right now, and we're actively working. And as Mickey keeps saying, we have to meet the industry where the industry is today. Right? So there's private sector, there's compliance, there's liability. I'm very happy to participate with all other QHINs here in advancing IAS. At least we're meeting halfway. It's not going to be ubiquitous for the next couple of years. Hopefully, we're on the path there to actually establish IAS in the way regulations are written with no special efforts, right? Today, there's still a lot of special efforts and a lot of friction points, but at least we're making progress on IAS.
Well,
But
we have.
Do they feel the importance and eventually, if not now, in a year down the road, the value in educating the consumer, the patient, helping them to how to upload the data and communicate with them? Do they believe in it, improving the quality of care at that point?
Some yes, and some are not focused on that. So depends
Okay.
on the organization.
Let's hear it for our panel.